Good day everyone. I will be discussing about inhalation injury. Inhalation injury is caused by inhalation of thermal and or chemical irritants. So there are two categories in it, the upper airway injury and the lower airway injury. Inhalation injuries are acute injuries to your respiratory system and lungs. They can happen if you breathe in toxic substances such as smoke, chemicals, particle pollution, and gases. Inhalation injuries can also be caused by extreme heat. These are a type of thermal injuries. Over half deaths from fires are due to inhalation injuries. There are two categories in inhalation injury, the upper airway injury and the lower airway injury. In the upper airway injury, the leading injury in the upper airway is thermal due to the efficient heat exchange in the oral and nasopharynx. While in the lower airway injury, it results from inhaling the products of incomplete combustion or noxious gases and is often the source of death at the scene of fire. Smoke inhalation injury can be defined as damage caused by breathing in harmful gases, vapors, and particulate matter contained in smoke. Smoke inhalation injury cause loss of ciliary action, trigger an inflammatory response causing hypersecretion, and produce severe mucosal edema and possibly bronchospasm. Alveolar surfactant production is reduced, resulting in atelectasis, or the collapse of alveoli. Expectoration of carbon particles in the sputum is the cardinal sign of this injury. Signs and symptoms of inhalation injury. Soot in the nostrils or throat may give a clue as to the degree of smoke inhalation. Skin color changes may range from pale to bluish to cherry red. Eyes may become red and irritated from the smoke. Cough. When the mucous membranes of the respiratory tract get irritated, they secrete more mucus. Bronchospasm and increased mucus lead to reflex coughing. The mucus may be either clear or black depending on the degree of burnt particles deposited in the lungs and trachea. Shortness of breath. This may be caused by direct injury to the respiratory tract, leading to decreased oxygen getting to the blood. The blood itself may have decreased oxygen carrying capacity. This could be the result of chemicals in the smoke or the inability of cells to use oxygen. This can lead to rapid breathing resulting from the attempt to compensate for these injuries. Headache. In all fires, people are exposed to various quantities of carbon monoxide. Even if there are no respiratory problems, carbon monoxide may still have been inhaled. Headache, nausea, and vomiting are all symptoms of carbon monoxide poisoning. Hoarseness or noisy breathing. This may be a sign that fluids are collecting in the upper airway where they may cause a blockage. Also, chemicals may irritate vocal cords, causing spasm, swelling, and constriction of the upper airway. Acute mental status change. Chemical affections and low level of oxygen can lead to mental status changes. Confusion, fainting, seizures, and coma are all potential complications following smoke inhalation. Tests and procedures. A number of tests and procedures may be done, which it depends on the severity of the signs and symptoms. For chest X-ray, the respiratory complaints such as persistent cough and shortness of breath indicate the need for chest X-ray. The initial X-ray may be normal despite significant signs and symptoms. A repeat X-ray may be needed during the observation period to determine if there is delayed lung injury. Pulse oximetry. A light probe is attached typically to the finger, toe, or earlobe to determine the degree of oxygen in the person's blood. Pulse oximetry has limitations. Low blood pressure, for instance, can make it inaccurate if not enough blood is getting to the parts of body where the probe is attached. Bronchoscopy. A thin, lighted tube is inserted through your mouth to view the inside of your airway to check for damage and collect samples if needed. For blood tests, complete blood count, This test determines whether there are enough red blood cells to carry oxygen, enough white blood cells to fight infection, and enough platelets to ensure clotting. Arterial blood gas. For people with significant respiratory distress, acute mental status changes, or shock, an arterial blood gas may be obtained. This test tells you the blood pH and can help the doctor decide the degree of oxygen shortage. Carboxyhemoglobin and methemoglobin levels. This level should be obtained in all smoke inhalation victims with respiratory distress, altered mental status, low blood pressure, seizures, fainting, and blood pH changes. It is now routinely done in many hospitals whenever arterial blood gas is assessed. Smoke inhalation treatment. Smoke inhalation treatment may include oxygen. It is the most important part of smoke inhalation treatment. It's administered through a mask, nose tube, or through a breathing tube inserted into your throat, depending on the severity of symptoms. Hyperbaric oxygenation, or HBO, is used to treat carbon monoxide poisoning. You'll be placed in a compression chamber and given high doses of oxygen. The oxygen dissolves into the blood plasma, as your tissue can receive oxygen while the carbon monoxide is removed from your blood. Pharmacological agents. Beta-2 agonists and muscarinic antagonists. The inhaled irritants in smoke cause severe bronchospasm, which is treated with inhaled beta-agonists such as albuterol, levobuterol, or salbutamol. Aerosolized sympathomimetics relax bronchial smooth muscles and stimulate mucociliary clearance. This decreases the resistance of the airway and improves dynamic compliance of the lung. The beta-2 agonists also have an anti-inflammatory action, reflected by attenuation of inflammatory mediators such as histamine, leukotrienes. Attenuation in pulmonary vascular permeability, pulmonary edema, and peak airway pressure with improvement of oxygenation has been reported with the use of nebulized albuterol. Tiotropium, a muscarinic receptor antagonist, has been reported to improve arterial partial pressure of oxygen and fraction of inspired oxygen ratio and decrease the peak airway pressure after smoke inhalation injury. Racemic epinephrine. Epinephrine has a vasoconstrictive action, thus attenuating mucosal submucosal edema in both upper and lower airway. It dilates terminal bronchioles, breaks the bonds in mucosal secretion, and attenuates the pulmonary flux of inflammatory mediators. Administration of nebulized epinephrine causes significant improvement in oxygenation, dynamic compliance of lungs, and airway pressure, and attenuates the airway hyperemia and pulmonary transvacuolar fluid flux in ovine model. The N-acetylcysteine has pulmonary antioxidant and mucolytic properties. N-acetylcysteine releases sulfhydryl radical, which breaks the disulfide bonds in mucoprotein. N-acetylcysteine stimulates production of glutathione, which protects cells from free radicals. N-acetylcysteine is an irritant to respiratory tract and can cause bronchospasm. Hence, with a mix of N-acetylcysteine with 0.5 ml with a bronchodilator, 0.5 ml salbutamol in 4 ml normal saline for nebulation. Aerosolized heparin and antithrombin. Smoke inhalation injury has procoagulant activity, therefore, aerosolized administration of anticoagulants is beneficial. Aerosolized heparin prevents indecision of secretions, improve microcirculation by breaking fibrin component of the bronchial cast, and has been found to reduce mortality in preclinical and clinical studies to smoke inhalation injury. Heparin exerts its anticoagulant effect by binding to antithrombin, and its effect is limited in antithrombin deficiency. Antithrombin deficiency is common after burn injury and correlates significantly with increased mortality rate and longer hospital stay. Antithrombin has anticoagulant and anti-inflammatory activity by inhibiting transduction of inflammatory signal. Treatment modalities: humidified oxygen, intubate if necessary if there is respiratory distress, hypoxia or hypercapnia, stridor, deep burns to face or neck, blistering or edema in oropharynx. Place a large endotracheal tube to help manage secretions and debris. Hyperbaric oxygen, intubation mechanical ventilation, IV fluid therapy for supportive care with treatments of burns. For nursing diagnosis and effective airway clearance: assess airway for patency, assess respirations, note quality, rate, pattern, depth, flaring of nostrils, dyspnea on exertion, evidence of splinting, use of accessory muscles, and position for breathing. Note for changes in heart rate, blood pressure, and temperature. Note cough for efficacy and productivity. Near drowning is a term typically used to describe almost dying from suffocating underwater. It is the last stage before fatal drowning, which results in death. Fatal and non-fatal drowning typically begins with a period of panic, loss of the normal breathing pattern, breath holding, air hunger, and a struggle with the victim to stay above the water. Reflex inspiratory efforts eventually occur, leading to hypoxemia by means of either aspiration or reflex laryngospasm that occurs when water contacts the lower respiratory tract. Hypoxemia in turn affects every organ system, with a major component of morbidity and mortality being related to cerebral hypoxia. Someone who has nearly drowned may be unresponsive. Other symptoms include cold or bluish skin, abdominal swelling, chest pain, cough, shortness of breath, vomiting. Tests and procedures: CT scan. A CT scan may show brain edema. The person may be given a dye before the scan. Tell the healthcare provider if the person has ever had an allergic reaction to a contrast dye. ABG or arterial blood gas. It shows oxygen and carbon dioxide levels. Blood is taken from a vein in the wrist, arm, or groin. Blood and urine tests. It can get an information about the person's overall health. Chest X-ray. A chest X-ray may show lung problems such as pneumonia, collapsed lungs, or ARDS. Electroencephalogram shows the electrical activity of the brain. Small pads or metal discs are put on the head. Each has a wire that is hooked to a machine. This machine prints a paper tracing of brain wave activity from different parts of the brain. Near drowning medical management. Bronchospasm from aspirated material may require use of bronchodilators. Antibiotics given only with clinical evidence of infection, not prophylactically. Central venous pressure, or better, pulmonary artery wedge pressure, guides use of vascular fluid replacement, pressors, diuretics. Treatment modalities: instigate or continue resuscitation as required. Intubate if unconscious. Give oxygen, and if the patient is awake and alert, observe for at least 6 hours. Pulmonary edema may develop late. It usually develops within 4 hours. Otherwise, the following may be needed: continuous positive airway pressure, intubation and mechanical ventilation with high positive and expiratory pressure, or even extracorporeal membrane oxygenation for severe pulmonary edema. Rewarming by extracorporeal circulation provides efficient rewarming and full circulatory support. Nursing diagnosis: impaired gas exchange. Assess the client's respiratory rate, depth, and rhythm. Auscultate lung for breath sounds such as crackles and wheezing. Monitor for signs of respiratory difficulties such as nasal flaring, stridor, retractions, and the use of accessory muscles. Provide oxygenation as ordered. For the prognosis, smoke inhalation injury patients are at high risk for complications. The majority of fatal burn cases are caused by respiratory failure, either from direct injury or complications such as pneumonia. Severe injuries often will lead to long-term complications such as bronchiectasis, bronchiolitis obliterans, and need for artificial airways. However, many patients will have no long-term sequelae from a single episode of smoke inhalation injury. The outcome of near-drowning victims depends largely on the success of resuscitative measures at the scene of injury. Patients who are successfully resuscitated and who are conscious on arrival at the hospital have an excellent chance of intact survival.